50% decline after we've already adjusted for about 100 other variables, including other comorbid conditions and the sociodemographic factors that you have. So, summary, measurement is important, but it's not easy. You all know that. The population perspective is very helpful, and we are just beginning to apply these rigorous research methods, but finding out that I think will help us with real guidelines that people can, or real rules of thumb that people can apply. So, thank you very much. Appreciate it. I'm going to introduce the next one. No, go ahead. You do it.
And there'll be time at the end of our panelists for question and answer. We left lots of time for that. So we're going to keep moving. I'm not going to do detailed introductions for our panelists to give them enough time. Their bios are in your packet. So first, without further ado, Dr. Parag Agnihotri for Sharpry-Steele, and then it'll go right to the rest of the panel.
Polling. For polling? For the polling, then you just have to click on the slide. This one. You'll help with the polling. Okay. So good morning, everyone. Thank you for having us. And I'm seeing a lot of familiar faces here. So again, it's glad to be back here. We just want to share with you, Sharpry-Steele. When we look at Sharpry-Steele, it has done an excellent job of managing diabetes and blood pressure control among diabetics. In fact, 85% of the diabetics right now have blood pressure control less than 140/90. But we know that we have some work, to do for blood pressure management in general for our hypertensive population. So the objectives of this talk are, how we can use Measure Up, Pressure Down campaign planks to really help us improve on hypertension data, things like the 4 planks we want to share our experience and how we're trying to implement. This is basically like boots on the ground around hypertension data registry, how we're trying to do physician engagement, looking at medication bundling, and self-engagement and telehealth blood pressure monitors. So those are the things we are working on. So I think first of all, when you look at our results based on publicly shared data on your OPA website also. When we look at RCI, Right Care Initiative goals and AMJ goal, we are striving for 80% control. When we look at California commercial population, the rate it says is 47% control, and I think that data is inaccurate because it was a test measure last year, and most likely not every group really reported the data. But Sharpry-Steele, based on commercial patients, commercial insured patient for 2013 had a control rate of 73%. Which technically places us around 90th percentile in California, and then on the highest quartile based on the AMGA data shared by Kendra and John. But really, that's not really good enough for us. I think we know Kaiser, and I think I'm just looking in front of sitting in front of me here, have a higher rate, and we have to really improve towards 80% control thing. So how are we using some of the planks? And some of the planks are around, for example, registry, and hypertension data registry, how we were implementing that. So let's few of the examples on those areas. First of all, we know that measurement is the first step that leads to control and eventually to improvement, right? Means I think we have always said, you can't improve things what you can't measure. It has been attributed to Deming, and Deming has said, I never said that. But anyway, I think, so there is a controversy, but basically we have to measure what we have to improve, we have to measure what we are trying to improve. So there are some things, fun facts, Hattie wanted to make sure that I have an interactive presentation, so I did look up some questions for you. So here is the thing, if you can poll, based on, there was a survey on 50 cities, and which of the city had the highest problem, biggest problem with blood pressure risk factor and complications. And you're helping me, okay. All right, so let's see the response. Wow, everyone knows Memphis. Very good, I think. So you're right. Memphis was #1 city with the highest, biggest problem, and San Francisco was the 50th city with the least amount of problem. And it's surprising that we have a conference just a few miles away from San Francisco. But I think when we look at San Diego was in the top 4, was the 44th city. And when we look at San Diego, and again, I think you were right on, spot on, 28% of San Diegans have blood pressure problem. And at Sharp Steele, for our membership, we have 33,000 members with hypertension. So when I saw those numbers based on registry, I just had to sit down for a few minutes and think of how I'm going to manage all this thing. So I think when we look at 33,000, and then when we start looking at expense, and again, a question for the group, what do you think is the annual expenditure for a hypertensive patient on an annual basis? Average. Take a guess. Wow, I think we have a really smart crowd. I think, Harry, you have done a good job of educating everyone. But $733 per adult. So if you think about it, we have 33,000 members. Each member is going to cost us $733. If we are accountable for this population, we are responsible for their cost. We have, it really behooves us to align with Right Care Initiative, AMGA, measure our pressure down, to really see how we can manage the blood pressure control. So right now, based on our registry data just a few months back, I think we have, this is for all payers. This is not for commercial. This is for Medicare, Medi-Cal, dual Mediconnect, anyone who comes into our clinics. 75% have blood pressure less below 140/90. But 24% do not have blood pressure control below 140/90. And of these, 3.5% had a blood pressure above 160/100. So I think we are trying to see now, look, how can we really work on this 24% and get it controlled? So I think the whole presentation, I'm trying to break it down into 2 parts, how we try to get up to 75% and what we are trying to do to go from 75% to 82%. So first of all, registry also is helping us also with hot spotting. When you think about it, it lets us know where the population is. We have in East San Diego, we have the highest number of patients with hypertension. It helps us to really break it down further, registry, based on the prevalence of each clinic site, so that we can see which site has the best practices, which site has we have challenge, so that we can deploy resources according to our the 18 clinic locations and where we can really work on. Then, the registry is really helpful. It's the whole care teams, all the care teams are working on the registry. Registries are color-coded, based on the range of if they're out of the range. The registry tells us about what are the current medications, what was the last appointment, when is the current appointment. So as much as information a team can use from registry really helps to drive the performance and helps to really align the teams around. So this is really, I think to John's point, I think registry is the first step, and we have to really, for any quality improvement project, a good registry is useful. The second few things, then you have registry now. How do we really address some of the other planks, which are blood pressure addressed every visit, and all patients not at goal seen within 30 days. This basically comes down to physician engagement, right? Means if physicians are not engaged in this, you're not going to get this. No one is going to measure this thing. So the whole thing is, how do we get physicians to participate and engage in this program? And if you look at it, these are the stats for our clinics. And at the same point, everyone is asking us to do something, right? Today's right now is hypertension. Somebody also wants us to look at chlamydia screening. There is one government regular agency wants us to do meaningful use of electronic health record by checking boxes while sitting in the front of the patient in the exam room, while our organization wants us to improve patient experience by making sure that we are not facing the computer while we are talking to the patient. So, right, and everything has to be done within 20 minutes because that's how we get paid. So I think, it's a challenge. It's an overwhelming responsibility. So the point is, how do you really get the buy-in in the organization? So here is a question for the poll, for the group. Effective ways to engage physician in a quality improvement project. All right, so I think, all right, the correct answer is simple outline on what you want patients to do. I think all the pharma people must have voted on the number D based on the campaign. No, but I think that D doesn't really go well, just from my side. But I think, basically simple outline on what you want physicians to do. And this comes from, a famous book, also Leadership, and basically, we think people know everything they're supposed to know, but sometimes we just have to state the obvious, right? What do you want your physicians to do? Do they know how to do the work? Do they have the resources to do the work? And are physicians motivated to do the work? We have to really align all these 4 things before we can really get going, So I think when Jerry was there at Sharp-Ristili, I think he had a very good philosophy, and I think he just implemented this for diabetes perfect care, just the 3 simple rules for diabetes care. Appointment every 4 weeks, lab every 4 weeks, medication titration every 4 weeks. And I think that's a great sound bite. Anytime you go to a department meeting, you go to staff meeting, you go rounding in the clinic, and people say, I have hundreds and hundreds of diabetic patients, I have hundreds and hundreds of hypertension. How do you really want me to take care of this? Well, 4 weeks. Appointment 4 weeks, lab 4 weeks, medication, and that's a slow and steady improvement. So breaking it down into simple rules has been really helpful. Second is, I think, clinical guidelines. There are so many guidelines out there, but I think they have to be customized to your own culture and workflows. And I think when we get together as physicians and look, or the pharmacists or clinicians, we get together, when we customize them according to our workflows, there is more acceptance of these guidelines rather than just taking anything from journals and publishing it. Also, when these guidelines are available online and people know that they'll be, for peer review process, they'll be judged on a standard measure, I think the acceptance really goes up. So that's our hypertension guideline. And again, I know there's a controversy about 150/90, but I think we are trying to overcome. Then we look at teamwork. I think, we know there's not enough hours on physician's schedule. We know that physicians, if you have to do everything 22 hours a day. But physicians, we have the team. Now, disease case managers, for example, they help us to really overcome the barriers. Care specialists, help us make appointments, make sure people are coming for labs. Clinic staff, I think the first step of checking correct blood pressure, is very, very important. Also, like Kaiser, I think, how people can come back and just have a walk-in for blood pressure check. And most importantly, pharmacists and pharmacy tech are very, very important. And I'm not just saying this because Marilyn is sitting in front of me, but I think RightCare has been on track right from day one, right, Harry? From first, the trying that pharmacists and pharmacy techs are very, very important in this whole hypertension management. So I think, and when we look at data registry, we have to always make sure that registry is accurate. As you know, I think many of you in this room know, you have one piece of information which is inaccurate in that thing, what happens to the whole list? Everything gets tossed out. So 99 patients would be correct, 1 is wrong, everything is tossed out. And God forbid if that list goes to your chairman of the family practice and he just then sort of denounces the whole thing and the whole campaign goes down. So the data analysts, we spend so much time behind in data analysis, making sure that things are tested properly, validation is there, because we want to make sure accurate data is there, because the whole care team is working on making sure that there is a standard way we are approaching the patients. So I think those are the ways we can engage physicians. And then I think we can do a sunshining of the data or transparency of the data to really show how each physician is performing for his or her own panel. In my opinion, trying to show transparency of data before even resources are deployed, or trying to shame physicians into public, of how their performance is before the tools are there, might work one time. But if we have hundreds of measures to do and we have to stay in the group and I have to still work there for 5 years, I think, trying to provide resources and tools before public display of data is very, very important. And then, it's not just about physicians, right? It's also about patients. How do we really get shared decision-making, patient engagement tools? So these are some of the examples of the patient engagement tools where people can have shared decision-making. What are the first things you want to really achieve? Is it salt control? Is it, what are the blood pressure targets you want to achieve? So these tools really help people to really align and share decision-making thing. Medication adherence is very, very important. I think, when we look at our internal data for ACE, ARB, statins, and diabetes medication, almost, only 70% of the patients are taking their medications on a regular basis. 30% of the patients are not filling their prescriptions on an annual basis. It's possible that some of these patients are going to Mexico and getting the medication, right? Some do go, and they get some other things also. But I think, in general, that's still a small problem, I think. But I think overall medication adherence is an issue. So we are now, expanding our refill clinic, which is now called as Medication Therapy Management Clinic. And there are phase 1, phase 2, phase 3 of it. Phase 1 was just pure refills, but phase 2 is looking at adherence, looking at gaps. And for example, here is a protocol for blood pressure management, which every pharmacy tech, before they fill the medication, goes over these 4 or 5 points, so that, you could promote adherence. And these pharmacy tech are really working alongside the primary care physician, so there is a loop, continuous feedback loop. And change is hard. Change is hard. I think incentives and penalties, I think the incentives are going down. The number of incentives are becoming so small now. But I think the penalties are going up, right? Means those are the drivers. So when we talk to our physicians, we are trying to harmonize all these clinical measures. If you think about hypertension, it's across every measure, meaningful use, ACO. Also, as part of our San Diego collaborative, $5.8 million, the grant, I think we are all aligned with how we are trying to manage blood pressure control. So, I always say this, there is no reform without payment reform. But I think hypertension is one of the best measures where we have so much alignment towards pay incentives and penalties. So the second part, I just want to focus a little bit on how are we trying to go from 75% to 80%, and how to really, basically it's not just about control, right? It's also how do you reduce cardiovascular burden. So the 2 planks which we have are hypertension guidelines for used and self-management program. So at this stage, yes, thank you. So at this stage we have, we have to rely on our university best practice collaborative, right? Means I think at this stage, as part of the collaborative, we said, what are the next steps we should do? So we looked to our godfather, Dr. Jim Duddle, and who said, as a Kaiser, what are you trying to do? So the best thing is, if you can't control, you just send patients to Kaiser, to Ray, right? Or you go to your friends. And they said, look, we have a combination therapy, and I think Dr. Jim and Dr. Tony DiMaria and Kitty and Alan, everyone worked together and said, look, ACE and diuretic combination is more effective than just ACE alone. So he's been very kind for me to share this slide, so I just want to share this. And he showed it by data. He said, look, ACE alone, you can only get 9.7 drop in blood pressure, 25 drop in blood pressure with combination. He said if you use combination, your chances of having heart attack, stroke, and death goes down, right? And he said the death goes down by 17%. Means at this point, we were like, okay, where do we sign? So I think we had to then combine, we came up with a protocol to say a simplified blood pressure protocol, and to say how can we start people on ACE and diuretic combination, and this is the regimen. You start here and go up, then you add calcium channel blocker, go beta blocker. At this stage in my group, in our group, we are just focusing more on ACE and diuretic combination. We are saying, okay, just let's get people on ACE and diuretic combination, and then, we'll talk about other things. So I think that has been very helpful. The collaborative has been helpful, and I again thank Dr. Dill and Kaiser for their great work on this. The second thing we are looking at is high-risk thing. There are a number of high-risk scales, right? But Framingham is the number, Dr. DiMaria always says Framingham is the one which has been validated well. Well, I think, if you think, this has been there for many years, but why are physicians not using it? Because in a 20-minute visit, you're not going to expect physicians to go on a computer and calculate a score, right? So what we did was we have built a whole hypertension data mart, which has now risk score embedded into this. It's calculating, and our goal is to stick it in the EHR as a point of care tool so that people know what the risk score is. And based on this risk score, we are trying to drive a different workflows for the high-risk patients. So here, if I walk you through, if a patient has a blood pressure not in control and they're in high risk with Framingham, they get a wireless blood pressure cuff at home. They're monitored by a population health RN with a dashboard. Then we have a health coach coming on, And then a pharmacist will review the 3 or more medications if they have more than 3 medications. And again, ACE and diuretic combination is the first choice. And then there's a feedback loop to the primary care physician. So with this, I just want to share with you a recent pilot which we did with, just some of the results with, let's say, for example, 11 patients. The dotted line is blood pressure before the pilot, and solid lines are after the thing. And you can see for each of this, the systolic and diastolic blood pressure improved. And I just want to digress a little bit. There was one patient who, in fact, not only had but he was having swings in blood pressure, hypertension, hyper. So the 80-year-old gentleman, when I looked at his medication, he was on 4 or 5 medications. This monitoring helped us to reduce his blood pressure medication, cut it down to 3 medications. This way, because, orthostatic hypertension is going to kill him first, then hypertension. So I think this was really helpful in monitoring and managing some other thing. The other thing we are looking at, health coaching, and health coaching is around, I think there are many schools on health coaching, so I want to get your response. Which of the healthcare professionals are entering into the field of health coaching? Health coaching is a buzzword nowadays. All of the work. You're correct. Again, very smart. So everyone, I think, the question is now, what is health coaching and what should be the standards, right? We have we are trying to work as a collaborative to see what should be the standards and how was patient engagement measured. Because we know based on our population health programs, based on case manager, disease manager program, we have had 64% engagement rate. That's great. But those are, there are certified standards for it. For health coaching, we don't know, and I hope that next year we can come back and share with you if Harry invites. So I think this is all part of continuous improvement process. We are always trying to tweak and improve and learn from the best. But here is the thing, why are we trying to do this? So here is a question for you again. Right. So, okay. The correct answer is B, 14% overall reduction in mortality, right? So that's the, even a 5 millimeter reduction in blood pressure lowers your stroke risk by 14%. The answer D is actually, well, who answered answer D? Okay, that basically applies to me, right? Or people on this panel. I wish, Harry, you could have just moved the wine session to lunchtime. We would have more productive conversation, shared decision. But anyway, I think that's what's happening. So in the group level, we are starting to now calculate of how many cardiovascular hospitalizations we have reduced, how many stroke hospitalizations. So here you can see there has been decrease in CAD hospitalization, stroke hospitalization. This is really powerful for physicians and patient engagement because now physicians and clinicians know that for every action they take in their clinic, there is a long-term outcome. And this also goes down to how we really engage patients in it. And I think we are part of the San Diego Collaborative on Be There campaign. You must have heard about this last year. And I think Liz is also there. So I think all of the people Be There campaign is really trying to engage our patient partners in reducing the burden of heart disease and stroke. So I think that, there are many, many good examples in the group here. We just want to share some of this thing. We are always lifelong learners. And this is the final slide. I just want to summarize this. That when we look at registry, I think registry is important because it helps us with peer review and health hotspotting. When we look at physician engagement, let's keep it simple and centralized. When we look at team-based healthcare, who is on your team? When we look at patient engagement, let's measure the effectiveness of health coaching. When we look at medication bundle, the first line treatment, should be the cost-effective ACE and diuretic combination. For telehealth, the ROI has to be there, so let's look at the high-risk hypertensive population. And change is hard. Change is hard, but this collaboratives like this, the university best practices regional collaborative, and the AMGF support really helps us to really move forward, learn from each other, And I really think that we can do this together. So thank you for your time.